Well, thank you for joining us again. We're kind of continuing our Movember information series here, where we're trying to understand a little bit about men's health and kind of what all that entails, kind of demystify a few things. So today we have Dr. Scott Brown with us, who is a urologist here in San Diego. And thank you for joining us today, Dr. Scott.
All right, thanks for having me, Kyle.
Yeah, appreciate it. So I want to talk a little bit about, we kind of talked about some prevention in our previous series. Want to talk to a little bit about your work real quick, get your background, just so we can kind of inform everybody.
Sure. I'm a urologist. My office is in La Mesa, and we have a group called San Diego Urology Associates.
Okay.
I've been in town since 2000. I've been in a small private practice. I have two other physicians that work along with me, and we also have a mid-level provider. And we provide all aspects of urology care. Obviously, in terms of men's health, prostate cancer is a significant thing for most men, and so we treat that on a regular basis. There's also BPH, or benign prostate hypertrophy, which is men that have trouble urinating as a result of having an enlarged prostate. That's not necessarily related to cancer, but also
just daily function.
That's right. It affects their quality of life essentially. And the same thing with prostate cancer as well, although obviously it's cancer and it's more significant in a lot of different ways and has impact on people's lives. But there's also quality of life issues with whether people get treated, how do they get treated, what are the different options and things like that.
Totally. Now, we had kind of talked about some of that with Dr. Ross and kind of some of the MRI screening as opposed to some of the needle methods. And which kind of methods do you follow with some of that?
So I think it depends. I mean, nowadays, most people, the most common reason that somebody's referred for something for consideration for prostate cancer is because they have an elevated PSA. So depending on the age and the overall health of the person and some other factors regarding their own medical history, the standard would be to recommend either a prostate biopsy via, in my office, like what we call a systematic random biopsy, which is essentially 12 random biopsies, 6 into each half of the prostate, or nowadays with MRI technology, if for whatever reason a patient elects to have an MRI, you can also do MR-guided biopsies into areas that are abnormal on MRI, but realizing they don't biopsy the full aspect of the prostate like you would with a random biopsy.
Definitely. And have you seen outcome measures on either one of those that seem to be kind of more indicative of a success?
I think it's hard to say for sure. There's, the data is always ongoing, and obviously prostate MRI has developed over the last few years as a, an adjunct to all of this. I mean, 10 years ago, this wasn't really an option. Okay, but technology has improved. But they all have limitations. So if you do a systematic random 12-core biopsy in an office setting like we do all the time, there's limitations. I mean, you're using ultrasound guidance. It's not as good at visualizing internal aspects of the prostate where you're biopsying specific areas. There you're just doing local regions based on this 12-core template.
Got it.
Whereas when you do an MRI, so the limitation on a biopsy in that fashion would be you could miss a small cancer because the needle just didn't hit that area. Whereas when you look at MRI seems to be pretty good for higher grade prostate cancer. It does seem to miss some of the low to medium grade prostate cancers, but others would argue maybe that's not as clinically significant. So we really want to detect things that are more aggressive so that if somebody needs treatment, you can offer treatment.
Totally. And then now, so let's just say I'm a patient, right? So I've had some sort of symptoms to a certain degree. What would indicate me like kind of going to urologist? And where does that fall in kind of the sequence of events in the whole cascade?
So when we're looking at prostate issues in general, there's basically two components. You have the symptoms of benign prostate enlargement, or what's called BPH, benign prostatic hypertrophy, and then you have the other category of prostate cancer. And so the most common reasons why a male patient is going to get referred for a prostate problem is either because they have urinary difficulties that their primary doctor feels are related to their prostate, or they've done research on their own and they come to see a urologist, or they have either an elevation in their PSA, which stands for prostate-specific antigen, which is a blood test that's a screening test for prostate cancer, or they can have an abnormal feeling prostate that maybe their primary care detected, and they want to have the urologist check it out.
Okay, and then now they've kind of had one of those sequence of events take place. They come see you. What happens next?
So basically, if a patient's referred in, generally for a male patient, for example, we'll usually do just a history taking, kind of what are their symptoms, how long have these symptoms been going on, and then after we do whatever their symptom complex is and the things that are bothering them, then we move on to what are their other medical history. In other words, do they have heart problems, do they have hypertension, diabetes, etc. Right. And then we'll go into their past surgical history, their family history, especially with prostate cancer, because family history, it's a very
like direct correlation.
Yeah. So most people that have a family history of prostate cancer are going to continue to have prostate cancer in their family.
Okay.
So we do that whole intake thing, and then we do an exam. And usually the examination is kind of a head-to-toe initial intake examination, and then specifically we're going to do an examination related to the prostate, which is a digital rectal examination, which is a finger in the bottom to feel the prostate. And we're feeling for the size of the prostate, whether there's any abnormalities. We call them nodules. They feel like little bumps. So it would be like the way your knuckle would feel as opposed to the flat surface of the back of your hand.
Okay. And then let's just say that was the case. So first off, we need to understand that, one, if we're having difficulties with urination, that would probably be an initial sign that we would want to talk to somebody, right? And is that regardless of age?
Yeah, I think for the most part, most prostate cancer patients are detected because of a high PSA. In other words, an elevation in the blood test, whereas they normally have no symptoms. They may have symptoms just because they're in the age range where they start to get urinary symptoms, but they don't have symptoms that they would go to a doctor for that are bothering them or anything like that. So almost always, because patients will say all the time, well, how can I have prostate cancer? I don't really have any symptoms.
Got it.
Because they're thinking like, oh,
should be very
cancer
pronounced or obvious.
Right, should cause like something to happen, and it doesn't. It's because it's one of the few cancers that has a screening test, and the primary doctor will do on a yearly basis a screening test in men when they hit a certain age, etc.
So need to make sure we're going to the doctor regularly.
Exactly,
right?
Particularly if you have a family history of prostate cancer, those people. So screening goes like this. Basically, Caucasian men from 50 on, at the age of 50, they should have a PSA yearly and a digital exam yearly. Okay. If you have a family history of prostate cancer, it should start at 40. If you're African American, because there's a higher incidence of prostate cancer, African American men start getting screened at 40, and if they have a family history, ironically, they would be screened at 30. And so it seems odd to diagnose prostate cancer in guys in their 30s, but because of things like MRI, because of better screening, sometimes you do pick
it makes sense.
Right.
Yeah, it makes sense. Less invasive.
Right.
Right. So, and that's kind of what we were seeing with Dr. Ross too, and that was kind of his whole thing, is that like the risk of an MRI, very low.
Right.
Right. And then, obviously if there's no symptoms, it's hard to really understand. Right. But if there is family history and there's a low risk way to screen, it would make more sense to kind of lean into that conversation so that you can try to circumvent anything, because early detection, right, would arguably one of the best ways to, produce a positive outcome.
Exactly. And one of the other things that also happens is a lot of guys will come in where they have a high PSA and they've had a prostate biopsy and it's been negative for some of the reasons that we talked about. Maybe it doesn't mean they definitively don't have prostate cancer. It just means we didn't pick it up by the random biopsy. So in those guys, every time they come back, when their PSA is a little bit higher, it's hard to recommend, and no patient would really want to have a biopsy every 3 to 6 months just because their PSA is going up.
No, thank you.
So MRI really, helped that whole, group of people where guy had a biopsy 6 months ago, his PSA is a little bit higher. In the olden days, we might have recommended another biopsy. Some guys would have done that, but now we can use MRI. So MRI is a non-invasive way of determining, hey, maybe there really is something there. Maybe the biopsy just didn't get it.
Sure. And then when we look at just the enlarged prostate side of it, so this could be naturally occurring, right? Just based on an individual variance.
Right. So some of the BPH is basically hereditary. In other words, some guys come from a family where the men have enlarged prostates and have had symptoms from that, and then the son or whatever may generate the same symptoms as he ages. But typically, BPH symptoms would typically start in men in their 50s and above. Okay, now you can have guys in their 30s and 40s that have urinary symptoms, and their primary doctor might send them to a urologist because they can't figure out why they have those symptoms or how to treat those symptoms. But in reality, in terms of it being from prostate enlargement, it's much less likely because the prostate is a gland that starts off, let's say, smaller than a walnut in size, and as men age, the prostate grows because the gland gets larger. And this is independent of having prostate cancer. It's just based on benign enlargement that goes throughout life. So in theory, if every guy lived to be 110 years old, he might have a prostate the size of a tennis ball because throughout life it would have continued to grow.
Okay, so there's some natural things there. And then if the prostate grows on that PSA test, does that number change?
Yeah, so some PSA is affected by a lot of different things. It stands for prostate-specific antigen, but it doesn't mean it's specifically related to prostate cancer. So in other words, a guy can have an enlarged prostate, and his prostate by volume is just much higher, let's say, than his age group of other men, and that can cause the PSA to be elevated and have nothing to do with cancer.
So I don't necessarily always need to be directly scared or fearful of a number that is arbitrary on there, unless we have secondary screenings coming to see you, understanding that there's other ways to determine risk factors associated with these numbers. So so there's multiple different things that we need to kind of pay attention to. So those would seem to be like symptoms first off, making sure that we're getting regular screening as a whole. And then understanding with the different ways of testing that we choose the one that kind of makes best sense for us, our family history, our current health status, etc. But then now, let's just say worst case scenario, we find something.
Right.
What happens next?
So it depends. A lot of the situation is based on the age and the health of the person that we're talking about. So for example, if you take most men in their 80s, if you look at autopsy studies, for example, most men that die, elderly men, will actually be found to have prostate cancer and lived life and never knew they had prostate cancer. Why? Because it was never assessed, because they didn't die because of prostate cancer. They died with prostate cancer. So there's a big difference. If somebody sends a patient in who's 85 years old that's got some heart and lung history and his PSA is a little bit high, we usually leave it alone. And we say, look, this is appropriate for your age. More than likely, statistically, you're not going to die because of prostate cancer. So what we're really talking about is in the screening age group of those ages that we talked about before. So a guy comes in and let's say he's 55 years old and he has a PSA that's elevated. Elevated for a 55-year-old guy would be greater than 4.0, right? Okay. So let's say he has a PSA of 4.5, and whether or not he's ever had a PSA before or even in the prior year, maybe his PSA runs 3.5, which is normal. So now the PSA is elevated, and we do the exam and go through his medical history. Let's say he has no family history of prostate cancer, and his digital exam feels normal. There's no abnormalities to the prostate. So normally in that guy we would say, okay, excluding any other factors that could have elevated the PSA. So what could elevate the PSA? People can have an infection. We can assess that by just simply talking to him. If he doesn't have symptoms of infection, we also do a urinalysis, and if there's no infection, then that probably didn't cause his PSA to be elevated. Some people get their PSA taken after they're avid bicyclists, for example.
Okay.
And they've been riding a bike every day, and they get their PSA drawn, and their PSA is high. A lot of pressure on the area where the prostate is.
Physically stimulating.
That's right. So that can elevate the PSA. And also, some men that have, sex, let's say before they get their PSA done and they've ejaculated within 24 to 48 hours, that can also elevate the PSA. So if you have any of those circumstances where you think, well, this may be artificially elevated, then we might repeat the PSA in a couple of weeks and just verify that it's really abnormal.
So you take a couple different readings to kind of find a normal reading.
Usually, unless it's pretty straightforward. The guy has no symptoms, he's 55 years old, his PSA runs in the 3s, and now his PSA is 4.5.
It jumps up.
So that guy is basically got an elevation of his PSA, and we have to at least offer the evaluation. So we would basically say, look, these are the different options. One option is you can have a prostate biopsy because your PSA is elevated. That we do in the office. It takes 10 minutes. We use local anesthesia. It's done what's called transrectally, which means we put an ultrasound probe into the rectum, just like we would feel the prostate, and that maps out what the prostate looks like. We can look for abnormalities, and then we do 12 random biopsies into the prostate using a standard template, which is worldwide. If you do this in Germany, they're doing the same thing. Or we say, okay, one option is a prostate biopsy. The other option is to do a prostate MRI. And we would say prostate MRI is just like undergoing any kind of MRI, but there are only certain centers where they offer this 3 Tesla prostate MRI, right? So it's a little bit more sophisticated than what most radiology centers would have. And then we say, you know, you can do the MRI. The MRI is, all it is being in a tight, you know, like claustrophobic type of experience with a lot of loud noise. But other than that, it's non-invasive.
Right.
And then usually they'll do the MRI and then they'll come back to the office and we'll review the MRI, you know, after it's done. And what the MRI is looking for is tumor suspicious regions of interest. So they're looking at diffusion characteristics based on what radiologists do, and they say, okay, this area looks such and such abnormal. And then they have a grading system, and the grading system goes from 1 to 5. It's this PIRAD system, and 1 being the lowest or least worrisome, 5 being the highest or the most worrisome. And what that 1 to 5 means is they look at a specific area, and when they assign it a number, that gives a statistical probability that if that area were biopsied, this is what the likelihood that it would be cancerous. So with 1 and 2, it's very unlikely. With 3, which is indeterminate, usually pretty unlikely. We don't usually go after those most of the time. And 4 maybe carries, you know, let's say up to 70% chance that it might show positive. And a 5 is almost always, it's pretty good that that's going to show prostate cancer.
Okay. Now, I'm scared, right? I went through this whole thing. You're telling me cancer. Now it's like 5. Now like I have a cancer. But then you're saying that like a lot of older people are dying with cancer, not from cancer. So what would influence me to want to have some sort of surgical intervention or other type of intervention there?
So let's say that we've gotten to the point where the patient had the biopsy or had the MRI, and even the MRI showed an abnormality, and then we had the radiologist directly biopsy into the abnormal area. But at the end of the day, the patient's diagnosed with prostate cancer. So when you're diagnosed with prostate cancer, pathologically or histologically, a pathologist looks at the abnormal tissue and they have to give it a grade. So there's a Gleason grading system for prostate cancer. It ranges between 1 and 5. Again, nothing to do with the MRI.
Yeah, just similar. Similar.
So 1 is low grade cancer, 5 is more high grade cancer, and then they take, that's called a Gleason score. That's what it looks like when they look at it histologically. They take 2 Gleason scores and add them together, and it forms a Gleason sum. What are those 2 numbers? Those 2 numbers are what is the most of the cancer pattern that you see under the microscope, and what is the second most, okay? So it's going to range, so it's 2 numbers between 1 and 5. So your Gleason sum total is going to range between 2 and 10. So those numbers, 2, 3, and 4 are low-grade cancers that you almost never see in a biopsy. Probably wouldn't even need to be dealt with. 5 and 6 are considered medium-grade cancers, for lack of a better term. 7 is kind of in its own little category because it's a little bit worse than 5 and 6, but it's not as high grade as 8 to 10. Okay, so 7 is basically, we say medium to high grade, and 8, 9, and 10 would be high grade. Now they quantitate it by, you know, intermediate risk and things like that, but to simplify it, so that's what we're basically looking at. So with this 55-year-old guy we talked about, he's got a PSA of 4.5, he had the biopsy, and let's say that he has, of the 12 biopsies that he had done, let's say 2 showed Gleason 3 plus 3, which is 6. So you may say, well, what's 3 plus 3? You know, one's the most and the second most. That just means the whole pattern was a 3. Okay. So he has Gleason 6 out of 10 cancer with a PSA of 4.5. and he has fairly low volume cancer because only 2 of the 12 biopsies were positive.
Okay.
So then usually we would typically do like a metastatic workup, but the chance of this particular patient having metastasis from prostate cancer is really low. Because statistically, Gleason 6 cancer with a PSA of 4.5 usually doesn't metastasize. But let's say he wanted to go through the testing. There's a bunch of different tests that can be done radiographically and with lab tests. And let's say he's shown to not have any evidence of metastatic disease. So now he comes back to the office with his wife or with his family, and we're going to go through a whole consultation session to basically go through the different options. And so that's where you look at, like, okay, how much of a worry is this? What do I need to do if I'm the person in that category? And it generally comes down to, when you counsel somebody who's diagnosed with prostate cancer from a urological standpoint, you're sort of categorizing that person into, can they do active surveillance, which is a way of monitoring it, and there is a protocol that we follow with active surveillance. It's not like we're just saying, okay, we're not going to do anything, we'll never see you again. Okay, so active surveillance requires a certain protocol if they go down that road. And then there's what's called definitive curative therapy for prostate cancer, of which there's a bunch of different choices. And then there's a category where you can treat prostate cancer to control it or to contain it, but you're not eradicating it, okay? So, and when I counsel people, we usually start off by saying with the person, the 55-year-old guy is either going to be in the active surveillance category, especially with this low volume cancer.
So keep an eye on it.
Or he's going to get treated. And so when you look at the different treatment options, then you have the option of radical prostatectomy, which is surgical removal of the prostate.
And that changes some daily function stuff.
Correct. And that's most commonly now, it's pretty much only done with this robotic technology to make it less invasive. So it's called robotic assisted laparoscopic prostatectomy. But it's the same type of laparoscopy that people would have their gallbladder removed as a minimally invasive way of taking out the prostate. And yes, when the prostate is removed surgically, you're basically, one end of the prostate is the bladder. You have the bladder, then you have the prostate, and the water channel of the urethra runs through it, and then it comes through the penis in the urethra. So you're physically removing the prostate, you have to sew the bladder back to the urethra. And so to do that, that's right. So to do that, it's kind of precise surgery that you want everything to attach and heal correctly. But some of the side effects of having radical prostatectomy or removal of the prostate are, it can have an impact on the urination, so there's a risk for being incontinent. It's a pretty low risk nowadays, but it does exist. And there's a risk for having problems with erection function.
Now that we have this different kind of varying versions of watch it, treat it, so now we're treating this. We're going to potentially remove it, which could change daily urination, change some sexual function as well. So that's more when we're finding aggressive forms of cancer that are either, and that was one of the questions, was when we're finding these biopsies and those things, we're determining amount of cancer or types of cancer, and then that is determining kind of the intervention that's recommended.
So most of the prostate cancer is one type, pretty much exclusively. It's called adenocarcinoma. There are some variants that are very, very rare, but for the most part, almost everybody's diagnosed with adenocarcinoma of the prostate. So what we're looking for in the biopsy is the grade of the cancer, the volume of the cancer, which means how much of each piece of tissue had cancer, where there is cancer, and then how many of the 12 biopsies, or in MR-guided biopsies, what percentage of those carry cancer. And then there's actually been, in the last few years, there's genetic ways of looking at the actual, for lack of a better term, DNA of the cancer cells to say, okay, this is 6, which is normally not very aggressive, but this carries an aggressive pattern.
All right, so we're talking about, there's primarily this adenocarcinoma that we're finding in there, and there is new genetic testing that is allowing us to determine really how dangerous this could potentially be. And that's, how recent is that? How new is that technology?
It's probably been out for a few years, 4 or 5 years.
Okay, but still fairly new in the game. And that's now steering some of the direction of treatment.
Right. It's actually, I believe it's more useful for people that may be reluctant to do active surveillance, but this might give them another boost to say, look, you had low volume, low aggressive disease, and the genomic testing or genetic type testing basically indicates that it's low aggressivity. So the guy might feel more comfortable going on surveillance, whereas if it was high aggressivity, even though it only measured a 6, he might say, well, maybe I should do something or follow it more closely or whatnot.
Definitely. And are you seeing that like across the board people are using that, or is that something people are having to request?
No, everybody should be using it. I mean, for the most part. I mean, I think it's limited by most people that have commercial health insurance or Medicare typically can get those types of tests.
Okay.
Sometimes when people are in HMO plans, you'd have to ask for it, let's say, for it to get done.
So, and this is where we want to kind of coach behaviors for people and just understand to be kind of their own advocate within this conversation, trying to educate themselves as much as possible. So, it's just, we're talking, get regular checkups. Pay attention to your PSA. We want to see big changes over short periods of time. But we do need to understand that if we're active, that isn't necessarily going to be the end-all be-all of the determining factors that we have a problem or no problem. There seems to be some genetic components to the size of the prostate which could indicate a higher PSA. There also seems to be direct correlation with some family history. It also naturally grows as we get older. And then there's these layering in different versions of tests, whether they be from MRI, the randomized biopsies, and then even after some of the biopsies, understanding, some of the genetic testing that can even tell us even more so.
Right.
But now, what percentage of all of these people that have now had biopsies and are kind of finding that they have a version of cancer are really determining that to be a really aggressive cancer that could be life-threatening?
Well, I mean, it's hard to answer that question, but most people that undergo regular testing with a primary care physician or a medical doctor, and they get their PSA done every year, and they get the digital exam done on a regular basis, most of those people don't show up with really aggressive prostate cancer that's going to be life-threatening. Okay. Almost everybody in those circumstances that gets diagnosed with prostate cancer is treatable or able to be on surveillance or managed in some way where it's not going to be immediately life-threatening. Doesn't mean that it's not going to be psychologically disturbing to them to know that they might have prostate cancer, but for the most part, most guys are highly curable when they're diagnosed.
So that's positive, right? It's a very positive thing. So I think there's a big stigma around this whole concept, and we hear the word cancer, and it's a very scary word. And I think, especially for people who may not be in the know, it's terrifying.
Of course.
Right? So I think it's good to know that in general, the biggest thing that we would recommend is like regular detection, right? Regular exams and things of that nature. Now, outside of some of those things, when we talk about maybe some lifestyle, behavioral factors, what are some other things that you recommend people to do, whether it be in regard to like exercise, nutrition, other lifestyle factors that could have a positive influence on this?
Yeah, I mean, I think that there are some supplemental things that can be used in terms of prostate cancer prevention, whether or not they're totally proven modalities.
Yeah, direct or indirect correlation.
Right, exactly. Right. But there's no doubt with any kind of situation of potential cancer, I mean, lifestyle has some sort of impact, whether or not it's scientifically proven, meaning if somebody exercises and in good overall health and doesn't smoke and basically, has relatively balanced nutrition, those people are basically doing the best that they can do in those situations. So clearly, like, the incidence of prostate cancer and cancers in general may be less if people choose a better lifestyle rather than a sedentary lifestyle, etc. And when you look at prostate cancer in areas like Japan, where they drink a lot of green tea, the incidence of prostate cancer is very, very low. In the United States, where the diet has, more carbohydrates, more fat-containing diets, there's a much higher incidence of prostate cancer. Whether it's a direct correlation or not, clearly lifestyle has some impact.
Totally, and I think that's when we're talking about wellness and well-being and how our lifestyle behavioral choices can kind of have this more aggregate effect as a whole. and it seems to influence more how our body responds, not necessarily what happens to our body, right? Which can keep us stronger, longer, those types of things. And so, you know, that's one of the things that we try and promote here also, right? Is this kind of holistic approach to this, making sure people are not only just doing the right thing when they're doing it, but that overall we're doing something versus no thing, that there is some sort of conscious effort that we're taking to our food choices, to our exercise habits, those types of things. I think a lot of that can get lost in translation over longer periods of time, and then we just kind of succumb to I'm getting older and this and that and the other thing. But really the aggregate effect over long periods of time does seem to have this profound influence on overall wellness. And then when we talk about worst case scenario stuff, we would then be better off on the other side, right? When we talk about recovery from this, when we talk about vitality in life after an incidence of cancer or things of that nature.
Yes, exactly. And there's also, I mean, when you look at, for instance, obese men, even if they needed to contemplate treatment for prostate cancer, surgery is going to be harder to do because their body habitus is larger.
Yep.
Radiation may not be as effective, although it may not be as influenced as, let's say, surgery does. But overall recovery is going to be impacted by somebody's ability to move around early, be more active, and overall just kind of get their conditioning back to a point where it allows them to recover in an appropriate time fashion rather than have complications that are related to immobility and, you know, difficulties getting around and getting back to normal.
Yep. So, I mean, and that's I think the biggest takeaway that we can have, right? What can I do today, right? Now, I think when we talk about resources for individuals, you know, it'd be great if what do you recommend people to kind of, is there websites, are there books, is there other information that you provide to people, just in general when we talk about this whole conversation?
I mean, we have information on our website just about general urological topics, prostate cancer being one of those, BPH being one of those. And so people will have resources like that through individual practices, but there's a plethora of information online. I mean, some of it is good and very accurate, and some is not. But most people, I would say that once they're diagnosed with prostate cancer, most of those men will typically go through a whole Google thing, and they'll be inundated with lots and lots of information. But most of those guys do try to get educated on this when they're diagnosed. They may not do all this before they get diagnosed with prostate cancer, but clearly people look for resources after the fact when they realize they might have a real problem.
And just if we're looking overall, not necessarily referencing good or bad versions of cancer, if you will, like what's the prevalence of this in men? Like when we talk about it as a whole?
I mean, prostate cancer is one of the top 2 or 3 cancers in the male population. And when you look at it overall, it's probably not as prevalent as some of the other cancers when you incorporate men and women, but it's still on the high side. And the thing about prostate cancer is, if prostate cancer is diagnosed relatively early and treated relatively early, the probability for success is very, very high, like in the 95% range, meaning most people are going to be cured.
I'll take that bet any day.
Right, and so the real message in all of this is to do appropriate screening and be aware of these things before you just show up to a doctor one day where you've never had any testing before, and especially if those are people where they have a family history of prostate cancer, and all of a sudden they show up and their PSA is 30, you know, and they're in a bad way relative to maybe 2 years ago their PSA was 5, and they could have been dealt with then.
Yeah, definitely. All right, so I mean, I think that was a lot of really awesome information. I really appreciate you taking the time and stuff today. I think there's a lot of people just don't really talk about it, I think is probably one of the bigger things. And one of the things that we like to have is really like you should be part of your primary healthcare provider. So there is some part where you win and lose. You should be part of the conversation. You shouldn't just blame a system or an individual for an outcome. And understanding that there's plenty of information available to individuals, and there's also plenty of things that I can do today and tomorrow that can benefit my outcomes. These whole things, whether it be from regular screening or whether it be from lifestyle behavioral choices, that can have huge outcomes. So, you know, being in charge of this conversation to a certain degree as a patient, I think, and I'm sure for you as a doctor, when you have somebody that comes in that has made the right choices over the last 20 years, that is also, you know, informed to a certain degree, is that an easier patient for you?
Yeah, I mean, I think patients that are aware of their own situations and obviously have an understanding and an interest in understanding it, I think are easier to deal with in a way, because you're not presenting them with information that's so far-fetched where they just become in denial and they don't want to deal with it. Right. A lot of people show up to the urologist office because they're in that age group where their friends are being diagnosed with prostate cancer, and they're seeing the reality of, hey, this really happens. Maybe I should go get checked out. I've never been evaluated before. Totally.
So definitely, you know, make your appointments and don't be shy about it. And if you're feeling something, you know, talk about it, make phone calls. And we really appreciate your time today. Thank you so much for coming by.
Thanks, Kyle.
Thank you so much.